there. Welcome back to the Complicated Kids podcast. I'm your host, Gabriele Nicolet. I am a toddler whisperer, a speech therapist, and a parent coach. And today I have Dr. Rae Stout. Dr. Rae, welcome.
Thanks so much. Thanks for having me.
I'm delighted that you're here because today we're going to be talking about auditory processing disorder and some ins and outs about that. But I want you to introduce yourself a little bit and tell the good people who you are and what you do.
So I am an audiologist. I have a doctorate in audiology. I went to University of Maryland. I went to George Washington University. I got my doctorate online, and which is interesting because I'm a virtual audiologist. I did a virtual degree at A.T. Still University in Arizona, the Arizona School of Health Sciences, and I've been in the field now since 1999, so just about 25 years in the field. I have worked in a variety of backgrounds, everything from corporate type audiology, like discount audiology, hearing aid clinics. I've worked in ENT. I've worked for private practices, and I've run my own private practice, which is a virtual audiology practice that specializes in neurodivergence and auditory processing disorders since 2017. I was one of the very first people to start working with using low levels of amplification for patients with normal hearing but difficulty with processing sound.
Okay.
And that started in 2013.
Oh my God. Okay, that is where it gets really exciting. And I'm going to leave that teaser there because we want to go back a little bit here and talk about what is auditory processing? What is that? What is an auditory processing disorder? How do we figure out if somebody has that? That's like where we want to start for just a second here, because those are seemingly simple questions that don't have simple answers, I think.
Well, you know, the grandfather of auditory processing, Jack Katz, Dr. Jack Katz, said that auditory processing is not your hearing, it's what you're hearing, what you do with your hearing in your brain. So there's a very big distinction between peripheral hearing, that is what your ears can actually hear, and what your brain does with that information. And for most people, it's very similar. If you hear well, your brain is able to use that information. It can understand where sounds come from in space. It can hear in background noise. It can pick up phonology. It can learn words. It can turn it into reading, and so forth, and access to language. But in the population I work with, there's a bit of a blockage. And I think of it a little bit like in a metaphor, sort of like imagine that the flow of learning in the brain was like a river from the time you're born until the time you die, okay? And if the river flows smoothly, if all of the information coming through your various senses flows smoothly, you're able to learn easily. You don't have learning disabilities or disorders of any kind. It's a very smooth, linear flow. But in the case of auditory processing disorder, there's something going on where some of those tributaries upstream are causing problems. And it's very hard to know what the original causes could be. It could be genetic. You know, it could be Ehlers-Danlos syndrome with the connectivity problems and fluctuations with how the ears are able to equalize and they build up fluid. It could be allergies. It could be food sensitivities causing congestion. And I don't know if you realize this, but there's a direct connection between having a history of ear infections and fluctuating hearing loss and an increased chance of incarceration.
Oh, wow. Mic drop. Okay. That's really interesting. And I'm imagining a very winding trail to get there, but that is a very interesting correlation. And we know some things about people who are incarcerated, which is that some enormous percentage of them have learning disabilities. And
especially dyslexia. It's something like 40 to 50% of both juveniles and adults in jails have dyslexia, which is why there's a senator in Louisiana right now, which I found out kind of after the fact. he's had a bill in Congress and the Senate down in Louisiana trying to get early intervention on hearing loss to prevent dyslexia in later life.
That's super
Um,
interesting.
it's been going since 2014. It's been stuck.
Yeah.
It showed up again about 2024, so last year.
Okay.
But what's interesting is, well, physicians' primary way of thinking obviously is with medicine and with surgery. My primary way of looking at it is that medicine and surgery are great, but they have side effects. Antibiotics have their own issues with the gut biome, and putting tubes in the middle ear can cause problems with, perforations of the eardrum. It can cause issues with losing the acoustic reflex because the eardrum can't pull tight to protect you against loud sounds. So I'm not against doing those things, but the thing is, if we try to intercede, even using something like these hearing aids temporarily, think of all of the downstream symptoms that might not happen as a result of the acoustic deprivation.
This is a really interesting thing you're saying. I've never thought about this. Correct me if I'm wrong. What I hear you saying is if we know that a child has recurring fluid in their ears, for example, let's not say maybe we'll do surgery, but maybe what we could do, and let's not just wait and see how this goes to see whether it resolves. What I hear you saying is let's pop some low gain hearing aids on this kid so that we can rest assured that this child is now hearing, compensating for their temporary hearing loss. If they have these low gain aids, no damage will come to, in other words, we're not over amplifying anybody. So if the hearing loss goes away, nothing bad is going to happen.
Exactly. I mean, it's the amount of power you're putting in there is maybe 10, at most 15 decibels. It's no more than an FM system.
Mm-hmm.
The chances of causing damage, if you think about it, if 50 decibels is speech level, 50 plus 15 is 65 decibels. If 85 decibels or more is required for weeks at a time to cause actual damage, 65 decibels is nowhere near that. So it's not going to cause any damage. What you're going to do is you're going to basically supersede or bypass. I don't know if supersede is the right word, but you're going to bypass the deprivation of the auditory system. You're going to make sure the two ears are equal so that they can tell where sounds come from in space and they don't learn proprioceptive problems and get all these anxiety issues of not knowing where sounds come from. You're going to make sure they're getting language, they're aware of their own speech. They're not going to develop the articulation issues. They're not going to develop the language issues, if that was the primary reason. They're not going to develop the proprioception and balance issues, possibly. All of those things don't happen. And because they don't happen, billions of dollars of therapy doesn't need to be spent.
So has this ever been done? Like I'm thinking of, many 3 and 4-year-olds in the country, in the world, who get ear infections. Have you ever put low gain hearing aids on one of these kids?
Well, I actually have a very interesting story. So there were a pair of 3-quarter twins. So the mothers are sisters, and they used the same sperm donor.
Okay.
And they had the babies at the same time and raised them in the same household, basically, like very nearby each other in the same local town somewhere in the US. And I'm not going to say where, obviously. But what was very interesting was the first mother came to me when her daughter was 3. They were both level 3 autistic children and nonverbal. The first mother was using sign language. The second mother wasn't. The first mother came to me. We fit the daughter at 3. She's now fully verbal. She started talking within a few weeks of the hearing aids. And now is maybe 6 months to a year behind in school at age 8. The brother, or whatever you would call him, the cousin, came at age 5, and the mother was much more, I would say, inconsistent about use, as well as not using signing in the home. And the combination of the two probably had an impact as well. He's now echolalic, Gestalt language, on a lot of medications, whereas the sister's not on anything. And he's years behind, but still probably better off than he would have been otherwise.
Mhm.
So I think, there's obviously more than one factor going on. One was consistency because of the level of safety in the signal. Another is, and also consistency of treatment. Another thing clearly was access to visual language. Very big deal. Using sign language or cued speech in combination with the hearing aids is probably the best way to go. But apart from that, genetically, they were almost identical.
That's so interesting. Yeah.
But I
And
can't tell you, I haven't done a large, double-blind study. I can tell you that I've seen huge amounts of benefit on kids at 6, 7, and 8. But if we caught them earlier, I don't think they ever would have needed to come to me.
so this is really interesting. So basically what I hear you saying is, if we suspect that there's a listening problem or a hearing problem. So those are two different things, right? One is like the mechanics of hearing. You can't hear because you have fluid in your ears. That's a mechanical problem. And we might do low gain just to kind of circumvent that. But then there's another problem, which is like a processing. I said listening. What I mean is a processing issue. And you said before we hit record, the tests are pretty bad for this. And I trained as a speech language pathologist at the University of Maryland, and like auditory processing disorder is basically a dirty word in the speech field.
Mm-hmm.
And nobody can agree on like what it is, what it isn't, how do you test for it, how do you know? Like, and so, as is often the case in the speech language pathology world, I'm finding like if you don't understand, you just shut it off because you might be wrong. But you have a very different approach, which is which is to treat what you see and then see if there's benefit. Do you want to talk about your approach a little bit in terms of just like how
Well,
you deal with people who come to you?
I mean, I often will start with the hearing aids before doing the testing because the testing is, I'm very good at doing the testing, but the testing is not very strong. I actually have seen a study that showed that it was like a meta study, and it showed depending which combination of tests that you included in your battery, you could see anywhere from 4% to 97.5% of the kids you tested show up positive for auditory processing disorder, which means it's meaningless. So the issue is that a lot of the tests look at these very basic skills. They look at, can a kid hear one beep versus two? Is it beep or is it beep beep? Can they hear the small gaps in sound? Can a kid hear if you put one word in one ear, one word in the other ear at the same time, and they have to repeat them both back at the same time? Like they repeat back the right ear first, then the left ear, then they have to do the left ear, then the right ear. So to get them to follow that direction is difficult in and of itself. And it's very linguistically based, because what if the child doesn't actually hear the word they're supposed to repeat? Or what if they don't have it in their vocabulary? So this is a real issue. And the problem that ends up coming up with the speech pathology field, and I got half of a speech degree at Gallaudet a couple of years ago. So I'm pretty familiar with the speech pathology viewpoint. Speech pathology viewpoint is looking at that river, and then they're looking at the debris way downstream and trying to figure out what actually happened, and thinking if they fix the problem downstream of the auditory issue, that it's somehow going to swim upstream and fix the problem that it started with. But that doesn't happen. If you break your leg and you don't set the bone and you don't use crutches, you're going to end up with a hip problem. And then you might end up with a shoulder and a spine problem. And now if you look at the shoulder or the spine problem and you say, well, I better fix that, it's still not going to fix the misset broken leg. This is the same thing.
It's so funny. This is the problem I have with all behavioral interventions at some level, which is behavior is a downstream effect of a neurobiological cause. And we
I
don't
mean,
often know what the cause is. And
I
so,
mean, even
yeah.
even APD, the upstream could have been poor sleep, it could have been genetics, it could have been poor socioeconomic status and poor nutrition causing the issues with the allergies, causing it's like the house that Jack built, you know? And but even so, APD is the bottleneck where everything dumps into the brain, where the peripheral problem causes a brain problem. So even when you look at a kid with an actual sensory neural hearing loss, chances are three different kids with the same 50 decibel hearing loss are going to have different degrees of processing because of other reasons. It could be they were raised oral, therefore didn't get the phonological understanding that a cued speech kid could have gotten. Maybe they didn't get raised with ASL, therefore, and I mean ASL from fluent deaf parents, not from parents who barely knew it. So maybe they didn't have a good L1 to learn English. And then when you look at and then maybe you have another kid who is raised with a very strong LSL, the very strong oralism focusing on auditory processing, and they're able to understand things at a higher level auditorily than they should based on their audiogram. You don't know. I had a friend who had 50 and 70 decibel hearing loss in one ear than the other, who had such amazing auditory capability. She would spend all day as a blood lab technician giving results over the phone with these old analog hearing aids. And the fact that she was able to do that is incredible, but you can have another person with the same amount of hearing loss who has never learned to speak. So even the hearing loss can cause auditory deprivation. The auditory deprivation can cause auditory processing issues. I'm not saying auditory processing issues couldn't be the first thing that happened, but my guess is in most cases it isn't. I think in most cases it's fluctuating hearing loss, especially asymmetric.
Mm-hmm. Yeah. Yeah. And, by the same token, we're not popping kids in brain scanners to find out what autism looks like in early childhood. We're not putting kids through rigorous hearing evaluations until, first of all, we can't. Second of all, well, I guess you could, but whatever. But at the pediatrician, like, if you are listening to this and you think, phew, my kid gets his hearing checked at the pediatrician, that test is, first of all, not a test, it's a screen. And it's pretty useless, would you say?
I would say if you took 100 baseball players and they all went through the same visual test at the pediatrician, it would be very hard for you to know which one can hit the ball consistently. And similarly, by testing auditory capabilities with beeps, you have no idea how well they actually can handle it. Who's going to become the concert pianist and who's going to sing off key and who can't hear in background noise and pitches a fit under the table.
So when parents, because it's mostly parents and educators who are listening to this right now, what are we looking for that might indicate, I wonder if there's a hearing or a processing issue here, like auditory processing issue? Like what are the downstream behaviors that we might see early on?
The major things you're going to see is that this is going to be kids who have vocabulary that's very uneven. They might have really strong vocabulary in a special interest, but really weak vocabulary in other interests that might not be things they care as much about. You're going to notice that they miss or they have like a forgetfulness or an inattention when it comes to multi-step directions. You're going to see that they get overstimulated very often with background noise, or they're just missing information. They're going to have a hard time with spoken directions in noise, especially if there's an accent that's unfamiliar, or it's rapid or soft speech, or it's at a distance. And they're going to have a hard time keeping up in group conversation, likely to see dyslexia, attention deficit, and autism, because they're very, very overlapping.
Yeah. Yeah. And so all of these things tend to travel together, which I think can make it harder to suss out, okay, where's the most bang for my buck, right? Like, do I go to speech and OT? Do I come see you? Do I do all of that? Like, people's resources and time is finite. generally speaking.
I think
What's your take?
I think the further upstream you can go, closer you can get to the source, the better. I mean, here's the thing. There's been some studies on attention deficit disorder and auditory processing and whether you can give things like stimulants to kids with auditory processing issues who do not have attention deficit disorder, and they find it actually makes no difference. Where it does make a difference is when you have both going on because you're taking off some of the cognitive load. But you can very often think that you see ADHD when really what you're seeing is a kid missing pieces of the information, therefore not being attentive because it's so much harder to keep in mind what you're hearing if you don't get a full piece of information. Similarly, a lot of kids that you think might have autism because they have Gestalt language, they're thinking like, Tetris, like they think in chunks of language because they can't hear the pieces clearly enough to make sense of the smaller bits. And since they're only hearing kind of chunks and hoping they can fit it together, they're seen as being autistic and they're reacting like they are autistic because they cannot break the language down enough for things like theory of mind. And they're going to get into special interests because it's easier to remember things you care about.
That's really interesting.
So, I mean, I think like, as an autistic and ADHD individual myself, when I take Ritalin, for example, it's, it definitely raises my anxiety level, but it really helps me with focus. And when you give a treatment trial of something like Ritalin to someone, you're going to notice a significant benefit to those people it's targeted for, okay? I think the easiest thing to do is to do a treatment trial if you're not sure which thing it is. Look at something like the medication, sure, but medication has risks. It has risks to your liver. It has risks to kids who might be bipolar or have mood disorders. The hearing aids don't actually have a risk. So if you try them and it does nothing, if you're working with the right person, they're not going to charge you for your time.
Yeah, tell me about that, because back to our earlier example of the 3-year-old who's got a middle ear fluid situation, isn't it very expensive to put hearing aids on kids?
Not necessarily because the parts are replaceable. So you, just like in the schools, they'll take these Roger Focus, they'll just change out the tubes and put them on the next kid. They can be cleaned and you can change out the part that goes in the ear itself. It's under the warranty. They can be thrown away. So the benefit to that is that you could take the same pair of hearing aids and fit it to 2 or 3 or 4 different kids over the lifetime of the warranty, which might be 3 years. And you don't have to have the audiologist buying a new pair each time. I mean, of course, if the parents want specifically their own set, they can do that. But they don't have to, just like the schools don't do it. As long as the part inside the ear is new and clean, it's not a big deal. It's about as bad as putting on someone's sunglasses.
And this is what you're talking about here is like, it's like leasing the hearing aids essentially for a period of time. We're not talking about aiding somebody in perpetuity. Is that right?
Typically, I mean, if you're talking about catching a kid really, really early on, sure, I would say that there's a decent chance they don't keep needing it, but you're going to find out because if you take it away and you see a big reversal, maybe they're not ready to take it away yet.
Yeah.
Just like if I gave you crutches and you weren't ready to put the crutches down and walk on your own, maybe you need to use them a little longer until your ankle heals.
I love that analogy because we're so used to thinking of, well, if you don't have a hearing loss, then you shouldn't have hearing aids. And what you're saying is that's stupid, number one, and not true. And it's also, it makes me think of my dyslexic friends who are performing, in air quotes, at grade level with reading, but they are so clearly below their expected potential and their cognitive potential because they're working so hard to do the work of whatever's happening that it's easy to say they don't need reading support, but they surely do. They really, really do. And so I love your crutches analogy because we would never send somebody home with a broken leg and not give them crutches.
I mean, it's really interesting with dyslexia. I mean, dyslexia, articulation, a bunch of other things. I'm not saying this is a snake oil. It's only going to work if it actually is working. But I can tell you, I had a little girl, in terms of articulation, then I'll tell you about dyslexia, who went for 7 years of speech therapy on, R, L, W, T, H, S, and SH. 7 years of her life spent. Within 2 months of the hearing aids at age 9, she graduated. Now, clearly, it was because of the speech therapy. Clearly.
And if you're not watching this on YouTube, you should, because we're rolling our eyes together. Yeah, 7 years is a really long time to linger, and then 2 months later. So,
and I had a little girl who started at age 9, also, who was kind of borderline on dyslexia, like really having to struggle, having to use audiobooks, getting very stressed. And within about 2 years with the hearing aids, her phonology was so strong, she no longer needed any dyslexia help. In fact, she went and tried to get re-evaluated and passed well within normal.
Wow. And so I want to go back to what you said earlier, which is, and I don't remember what it is, you're going to remember much better. The treatment effect will work on the people it works on. It was something like that. Like if we try something and it works, let's do more of that. If we try something and it doesn't work, let's not do more of that, apropos of like 7 years of speech therapy. Like clearly that wasn't working.
It's a physiological problem. It should have a physiological solution. And if you're able to fix the broken leg with a cast and crutches, and I'm not against doing the physical therapy, right? But if they don't need it, why are you subjecting them to it? So let them see if there's a way to heal on their own and then add therapy if needed. But kids only have a finite amount of childhood.
Yeah.
So why are we making them spend their time feeling disabled?
In a perfect world, Dr. Rae, what would this look like in terms of, if I'm going to wave a magic wand and everybody understands the importance of auditory processing on childhood and language acquisition and all the things. What does that look like?
Well, my feeling is a perfect world would be kind of twofold. First of all, I'm a big proponent of this cued speech, which is a visual system that gives phonology. So you're able to give the consonants, the vowels all visually, which would basically wipe out the problem of most of the dyslexia issues if they are phonological. Okay. Even if you have the hearing loss. And also, not everybody's an auditory learner. On top of that, it shows up on fMRI as auditory. And when kids who get cochlear implants who use the cued speech, it actually processes in the same area of the brain as auditory. That would be great. But on top of that, once you see a kid with more than 2 or 3 weeks of fluid, you put hearing aids on them. You may not have it as a perfect fit because perfection's not the issue. This is a blockage. What you want to do is at least give them better than they have within safety. I don't know that most practices have the capability of doing constant changes for fluctuating hearing loss because it's always up and down. But at least if you give them 10, maybe 15 decibels, it could bring them from 40 to 30. Or to 25 could be all the difference for that kid. And the ability for them to adjust it with the parents on the phone, another 5 to 10 decibels is still not dangerous. It's within that range. And then if one ear seems worse, giving it a little bit of a boost and then checking them to see if they can point to where they hear a sound could give a lot of help without a lot of expertise.
I love it. It seems so simple.
Mm-hmm.
And I can see, and I think at some point we're going to have to go back. We'll do another episode on why it's important to be able to localize sound, why it's important to understand where sound is coming from. And what that does to the body, but that's not today. In the meantime, if people want to learn more about you, your work, how you operate, what do they do?
Well, the easiest way to find me is through the website, which is just DrRaestout.com. I would highly recommend that you also put up a backslash and blog, because I have about 60 articles that you can read through to get an idea of everything from this pipeline, from ear infections to incarceration to what to look for and different things about visual language. It's pretty eclectic.
Nice. I
But
love
it'll
it.
also lead you into, we have a Facebook group of about 13,000 people. It's very active. I mean, considering it's a very niche topic, it's a big group for what a small topic it is.
Yeah. And I'm in there hanging out, and it's good in there. We will link to all of that in the show notes. And Dr. Rae, until next time, thank you.
Thank you so much.